First, we're going to talk about eyes, though, and I really don't like doing eyes, okay? Because my eyes are really, really sensitive. I don't like people messing with my eyes, right? And I certainly wouldn't like people sticking a needle anywhere near my eye. So, but we got to talk about it anyway, all right? So let's talk about eyes first. Good. So eyes are one of the most frequent, most common surgery for patients that are elderly. All right, eye surgery, cataract surgery, whatever it may be. Let's very quickly talk about anatomy of the eye. Some of this I expect you to know, some of it I don't. I'll let you know. All right. You know that the sclera is the outermost portion of the eye, is the outermost layer of the eye. The cornea is the anteriormost portion of the eye. All right. The uveal tract consists of the choroid, which is a layer of blood vessels that's located posteriorly. The iris is also part of the uveal tract. I don't care that you know that it's part of the uveal tract, but this is what you need to know, all right, for sure. The ciliary ganglion provides sensory innervation to the cornea, the iris, and the ciliary body. Parasympathetic fibers that change the size, the diameter of the iris, originate in the oculomotor nerve and a synapse in the ciliary ganglion. Those supply the iris sphincter muscle. Meiosis occurs, or pupillary constriction occurs by contraction of the iris sphincter muscles. The sympathetic fibers that innervate the iris originate from the carotid plexus. They travel through the ciliary ganglion. They innervate the dilator muscle of the iris. They cause pupillary dilation by contraction of the dilator muscle. So if there's a block there, been done, or some kind of blockade at all, then we see a fixed mid-dilated pupil. The ciliary body is part of that uveal tract. That's where aqueous humor comes from. Then you know what the retina does, and the center of the eye is all filled with vitreous gel. I don't know about you, that just grosses me out. I just don't like, eyes just weird me out at all, totally. I don't expect you to be able to remember this slide, nor do I expect you to be able to label anything on a test. I'm just putting it here for your information. I can't remember exactly which reference it came out of. There are 6 extraocular muscles that move the eyeball all around. The ophthalmic artery is a branch of the internal carotid artery and provides most of the blood supply to the orbital structures. The ophthalmic artery provides most of the blood supply to the ophthalmic structures, or orbital structures, pardon me. Remember that. The ophthalmic veins drain right into the cavernous sinus to carry blood away. Obviously, you know what the optic nerve does. It provides neural signals from the retina. The oculomotor, the trochlear, and abducens cranial nerves control extraocular muscle movement. The trigeminal nerve, which is the 5th cranial nerve, provides touch and pain sensation. The facial nerve provides motor innervation to the orbicularis oculi muscle. If the facial nerve is blocked, the patient cannot blink. And so therefore, it prevents a patient from squeezing their eyes shut. All right? So the patient can't blink, and they certainly cannot squeeze their eyes shut. Sensation to the upper eyelid is from the frontal branch of the ophthalmic nerve. Sensation to the lower lid is from the maxillary nerve. I don't care that you know about sensation to the upper and lower nerve, because you're not going to be blocking those nerves anyway. You do need to know what the cranial nerves do. The normal intraocular pressure is anywhere from 10 to 20 millimeters of mercury. You're going to read, if you were to look at other sources, you're going to see that it's 12 to 20, 8 to 20. Typically, the high number is always 20. All right, and so that the intraocular pressure is regulated by the quantity of aqueous fluid and choroidal blood volume. The blood supply to the retina and the optic nerve depends on what intraocular pressure is. So it is the difference between mean arterial pressure and intraocular pressure that determines the blood supply to the optic nerve and to the retina. Its resistance at the trabecular meshwork, which we'll talk about momentarily, its resistance at that trabecular meshwork that helps determine also, or primarily regulates intraocular pressure. So resistance at the trabecular meshwork primarily regulates intraocular pressure. And so patients that have glaucoma, they have increased resistance at the trabecular meshwork. And then the intraocular pressure, it can be increased by external means, by pressure on the eyeball. You applying pressure on the eyeball, believe it or not, it could happen, right? By malposition of the mask on the patient's face. You turn the patient prone, like Heinrich and I did last Wednesday. Our patient didn't have any problems, but you turn the patient prone. If her eyes are not properly positioned, or face is not properly positioned in the whatever device you're using, the prone view, then that can cause external pressure and increase the intraocular pressure. When you blink, when we blink, the intraocular pressure increases by 10 millimeters of mercury. That's a trivia question, okay? That's not a test question, all right? If you were to squeeze your eyes tightly, all right? Squeeze your eyes tight, that increases the intraocular pressure by 50 millimeters of mercury, 50. If there's any changes in the intraocular contents or any kind of scleral rigidity, that also is going to increase the intraocular pressure. Intraocular pressure is also increased by intubation, light anesthesia that causes coughing, straining, or vomiting. Hypercapnia also increases intraocular pressure. Ketamine is included here, but it depends on which reference you use. All right, we're going to say that ketamine does increase the intraocular pressure, and I'll give you a number in a little bit. I might actually have it, 2 to 3 millimeters of mercury, because of increased blood flow. So there's mixed bag, there's mixed references on it. Some say that ketamine does increase it, some say it doesn't. The references that I looked at primarily said, yes, it increases intraocular pressure by a negligible amount, 2 to 3 millimeters of mercury, because of increased blood flow. If your patient were to cough during intubation or extubation, that's going to increase intraocular pressure by 30 to 40 millimeters of mercury. The hypercapnia that you see there, hypercapnia or elevated CO2 is going to increase blood flow and cause I can never say that word, choroidal congestion. Succinylcholine is also said to increase intraocular pressure by 6 to 12 millimeters of mercury. It does that by constant contraction of the extraocular muscles. It only lasts for the length of time that the succinylcholine is effective, essentially up to 5 to 10 minutes. Things that decrease intraocular pressure are, well, volatile anesthetics or IV anesthetics that we deliver. Those have a dose-dependent reduction in intraocular pressure by 30 to 40% or so. Mannitol will decrease intraocular pressure for up to 5 to 6 hours. Acetazolamide will also decrease it because it's a carbonic anhydrase inhibitor. It's used to treat glaucoma, so it chronically decreases intraocular pressure. Because it is a carbonic anhydrase inhibitor, it can cause an alkaline diuresis, which could make your patient hypokalemic. Hypokalemic, where cause potassium depletion. Are you guys familiar with ecothiopate already? I've not seen any patients on ecothiopate or any derivatives of it in a long time. I haven't done eyes in a while, but still. You guys that are at JPS, don't tell anybody I haven't done eyes in a while, you hear me? I'll kick your butt if I find out. That means I'll be in the eye room soon. Ecothiopate is a topical, irreversible anticholinesterase agent. The goal is to maintain meiosis for the treatment of glaucoma. It can be absorbed systemically through nasal mucosa and lead to total body inhibition of plasma cholinesterase. So what's that make you think of? If I give succinylcholine, what's going to happen to that patient? It's going to last longer, all right? So if I give it to polarizing muscle relaxant, if I give it succinylcholine, it's going to last longer. And if I have a patient that is receiving ester-type local anesthetics, that's another concern that may lead that patient to having local anesthetic toxicity because of the inhibition of plasma cholinesterase. If your patient were to be on an ecothiopate drug or derivative, all right, and they stop it, they still have that effect, that decreased plasma cholinesterase activity or inhibition for up to 4 to 6 weeks after it's discontinued. The last drug is timolol, and it's a beta blocker that's used for the treatment of glaucoma. It decreases production of the aqueous humor to, again, treat glaucoma. I think there's another slide coming up about these in a little bit. If it's there, just forgive me. It's just a duplicate. This is just a slide from Morgan McHale that gives you a general summary of what I just said. Notice that there's a question mark up there about ketamine because there's some question about it. We're going to say again that ketamine does increase intraocular pressure by a negligible amount, meaning 2 to 3 millimeters of mercury. Okay, so because of increased blood flow. So that's just for your reference as well. All right. You have more reference for you? I just realized looking at that slide, I told you something wrong. I told you that, I told you that didn't I tell you that hypercapnia increases? Good, I want to make sure. All right, I couldn't remember what I said earlier. Hello, turn on your microphone, that way everybody hears it. Ma'am, Haley, Simon, tell me.
That, the slide right before this one?
That one right there?
Yep, nitrous oxide decreases your intraocular pressure.
Nitrous oxide decreases intraocular pressure.
I think we were told differently before because it's a globe essentially and you feel that pressure.
We're actually going to talk about that. It will initially decrease intraocular pressure unless the, what are they called? Ophthalmologist. I get those old doctors all messed up. The ophthalmologist injects a bubble into the eye to help reattach the retina and keep the retina flat. If he injects a bubble into the eye to keep the retina flat, then nitrous oxide will diffuse into that bubble faster than nitrogen because of fixed law of diffusion. We're getting ahead of ourselves here, but that's okay. Because of fixed law of diffusion, nitrous oxide moves or absorbs into that bubble faster than nitrogen, so that then will increase intraocular pressure. All right, so it's kind of a situational thing, whether it increases it or not. Did that take care of that? So you're not wrong. You're right, just in a situational sense. Everybody understand that? We'll come up to it in a minute. Okay, good. So the ocular cardiac reflex. We talked about this in, just a little while ago. Me and Taylor. All right, so and this is a real phenomenon. This thing. All right, and so it can be a little bit confusing too. All right, but this was first described in 1908. I don't think I care that when it came around, but it's what's called, say that word fast, trigeminovagal reflex, all right? The 5 and dime reflex, right? Everybody knows it as a 5 and dime. Triggers are traction on the extraocular muscles, external pressure on the globe, or a retrobulbar block, okay? Now, I'm going to tell you, here's a little thing that you're going to hear me say in a moment. The retrobulbar block can be a trigger, but it can also be a preventative way it can be prevention also. So it can be both a trigger for the ocular cardiac reflex, or it can prevent it, all right? And it's just, again, it's a situational, patient-specific thing. All right? This is most commonly seen in patients who are having strabismus surgery. All right? Typically, those are children. Children that are having strabismus surgery is who most commonly see it. And those kids can get bradycardic. They can become completely asystolic temporarily. I've never had one get asystolic, but I've had plenty get become bradycardic. You can see an AV block. You can see ventricular ectopy. So just be aware that it's typically in children. You absolutely must know the afferent and efferent limbs of this. Okay? The afferent limb is from the orbital contents to the ciliary ganglion, to the ophthalmic division of the trigeminal nerve, to the sensory nucleus of the trigeminal near the fourth ventricle. Okay, I know I said that fast, let me slow down. The afferent limb, this is the afferent, is from the orbital contents to the ciliary ganglion, to the ophthalmic division of the trigeminal nerve, to the sensory nucleus of the trigeminal nerve near the fourth ventricle. So it's all about the trigeminal nerve, right? So which nerve is responsible for the afferent limb of this ocular cardiac reflex? Now all together, the trigeminal nerve, all right? The efferent limb of this is the vagus nerve, okay? Last year when I taught this, I can't tell you how many people got this wrong. Please don't get this wrong, all right? So, because I told you, you must know it. The afferent limb is the trigeminal nerve. The efferent limb is the vagus nerve, okay? I know it sounds really silly to have to repeat that, but I want to make sure you know it. Because if you haven't been asked that in the operating room, you will, all right? How do you prevent it? Or is there a way to prevent it? There is said that you can give atropine or glycopyrrolate preoperatively to prevent it. If it happens, what's the first thing you're going to do? Tell the ophthalmologist to stop, all right? Please stop the surgery, okay? Then you need to assess the ventilation of the patient because the ocular cardiac reflex is going to get worse if your patient is hypercapnic or hypoxic. So assess your patient's ventilation. If you do have to treat it, then we'll treat it with atropine anywhere from 7 to 10 mics IV, or probably 7 to 10 mics per kilo IV. If it continues, then the ophthalmologist can infiltrate the rectus muscle with local anesthetic in an attempt to stop it. But it is also a reflex that fatigues itself, right? So it may just stop occurring if it's occurred repeatedly in that child or adult, whoever it is, all right? If it occurs, then one of the reasons it may just stop on its own because it fatigues itself. And remember that the retrobulbar block may be a treatment for it or may prevent it, but it also may be a cause of it, okay? Let's talk about open angle glaucoma. This is the chronic glaucoma that your patients come to you with, or elevated intraocular pressures. This is the absolute most common. Notice I said, remember that the primary determinant of intraocular pressure is the trabecular meshwork, the resistance in the trabecular meshwork. Well, this tells you that trabecular meshwork sclerosis is what causes that chronic pressure elevation. This is a gradual elevation and painless. The patients don't feel this because it's painless, all right? This is an optic neuropathy that's characterized by progressive loss of peripheral vision, followed by central vision field loss as well. We lower the intraocular pressure by topical medication, as we talked about before, or there's a way to decrease fluid reduction as well through medications. Or if those have failed, then your patient may come to you for a trabeculoplasty or a trabeculectomy. I love saying that word, I don't know why, trabeculectomy. is increased aqueous production and or decreased outflow of the aqueous humor. There are possible mechanisms for the chronic elevated intraocular pressure. Closed angle glaucoma, on the other hand, occurs from closure of the anterior chamber angle. It is from acute dilation of the iris, blocking drainage of fluid away from the eye. This causes a rapid rise in intraocular pressure, which is painful. If your patient is untreated in 24 hours, it can lead to blindness. So they must receive treatment in 24 hours. The treatment is to do an iridotomy, which sounds absolutely horrific to me, but then again, I don't like my eyes messed with. Okay? What is done is an iridotomy creates a small hole in the iris that allows fluid to flow freely into the front chamber of the eye, where it can then drain. If you have a patient that has closed angle glaucoma, what drugs would you not give to them? This is a test question, I promise. All right? You are absolutely not going to give the patient scopolamine. All right? Antihistamines and decongestants may cause an increase in intraocular pressure because of pupillary dilation from them. So antihistamines and other decongestants we have to be careful with. Certain antidepressants with an anticholinergic effect can cause pupillary dilation and increase aqueous humor production. Benzodiazepines can also be a problem because they relax the sphincter muscles of the iris and have a mild anticholinergic effect. So again, pupillary dilation can happen. Cocaine can cause acute closed angle glaucoma. Ecstasy and marijuana can also cause it. And the old drug, Atrovent, or ipratropium bromide, Atrovent, can cause that as well, because it's an anticholinergic. So basically, we don't want to give our patient any anticholinergics or anything that mimics an anticholinergic that would cause pupillary dilation. So don't be going and giving your patient any ecstasy. Hear me? Okay. We talked about acetazolamide. It's used for the treatment of chronic glaucoma, but remember that it can cause potassium depletion. So if you have a patient coming to you with this medication, then they definitely need their electrolytes checked. One common side effect of it is that it can cause post-op nausea vomiting. Ecothiopate we talked about as well. It's also used in the treatment of glaucoma to maintain meiosis or pupillary constriction. Once again, it inhibits plasma cholinesterase and will prolong suctional choline, the walk from suctional choline, and I believe it's for up to 20 minutes. The risk of post-operative apnea with suctional choline is not an issue, so it prolongs it up to 20 minutes. And remember, if you have a patient that has been taking this as well, that is going to stick around for 4 to 6 weeks after they've discontinued it. So you still want to avoid giving suctional choline to those patients. Other ophthalmic medications, we have to be careful or you're not going to be administering drops, but the preoperative nurses have to be careful about what percentage of phenylephrine they're given. Phenylephrine eye drops are not in the typical 10% that you would draw up to mix for phenylephrine infusion, okay, or phenylephrine bolus, all right? That's a 2.5% concentration. So when you see those brackets up there, that means concentration. So just be aware that phenylephrine drops that are given to a patient preoperatively should be a 2.5% concentration, not the 10% concentration that you would use IV. There is also pilocarpine and acetylcholine drops as well. These are used intraoperatively after lens extraction to cause pupillary constriction. The drawback to these is that they can cause bradycardia or bronchospasm. I told you about timolol. That's a beta blocker. It's a non-selective beta-1. It's used also for treatment of glaucoma, and it is contraindicated in patients that have asthma, congestive heart failure, or other conduction defects because of the probability of systemic absorption. This last drug is a newer drug that came around in 2017. I personally have not seen it for any patients, but then I haven't really been looking for it either. It's a Rho kinase inhibitor. I'm not going to ask you about this drug, all right? If you see it on the test, it's just to distract you, okay? I'm not going to ask you about this drug, so be aware of that. But if you were to see it on your patient, the goal is to it reduces intraocular pressure by increasing the outflow of aqueous humor through the trabecular meshwork. Checking time. All right, so what is a cataract? The cataract is an opacity of the crystalline lens of the eye. So this is by far the most common surgery that you're going to see for your patients. What happens is, back in years ago when I first started doing anesthesia, they did manual removal of cataracts, and it seemed like it took freaking forever. And then phacoemulsification came around, and depending on who's doing it, it can still take freaking forever, right? But typically this was supposed to speed up the time, and I've seen cataracts done in 10 to 15 minutes per eye. Usually you only get one eye done at a time, right? Because they want to see on the other side. But what the ophthalmologist does is makes a 3mm incision, and it's an ultrasound vibration, breaks up the lens fragments, and at the same time there's irrigation and aspiration of those lens fragments as well. Has anybody not done eyes yet? Several of you. How about you guys? So you haven't done eyes yet? Well, you will. You get that experience. You hope it's boring, okay? You hope it's boring. And am I right? Is it boring typically? And you really hope it's boring. You want it to be. And most of our patients are awake, right? And they're told to be still and so on and so forth. But it can be a pain in the butt, really. Then there's this word, the keroplasty. The idea of the keroplasty is that we're supposed to replace the infected, traumatized, or poor optical cornea. There are more than 80,000 of these done every year worldwide. And this is donor corneas are put in place, and the donor cornea now has a storage time of 7 to 10 days. And I put up there that is elective versus urgent procedure. The storage time now is 7 to 10 days. When this first came around in the 1940s, the storage time was only 2 to 3 days because they didn't have proper refrigeration and all the stuff that they needed for it. And so storage time was only 2 to 3 days for a donor cornea. It's increased because of technology increasing to 7 to 10 days. So you need to determine, or used to was an issue of, is this an urgent procedure or is it an emergent procedure? And how long has that cornea been basically sitting there? Is it like a stale cracker? You don't want to eat a stale cracker, right? You don't want, I don't want to gross you out, but you don't want to put a stale cornea in their eye either, all right? During this procedure, our goal is to maintain low and stable intraocular pressure. So mannitol is typically administered because remember that mannitol will decrease intraocular pressure for up to 5 to 6 hours, if I remember correctly. I'll make sure I didn't forget anything for you. These patients absolutely must have complete eye akinesia, so they cannot move. They obviously have to have good analgesia. We don't want that patient doing eye squeezing, so here's a good question for you. What nerve would you block to prevent that patient from squeezing their eyes shut? The facial nerve. Okay? You don't want that patient moving at all, their body. You don't want that patient coughing. We obviously need adequate perfusion, so fluid status is important. Blood pressure is important for eye protection, and we need to, quote unquote, abolish the ocular cardiac reflex. So they will benefit from a retrobulbar block. They may need a general anesthetic if they're not able to lie flat, or if they're restless, or if they're a patient with a tremor, or if the patient is claustrophobic, or obviously the kid is a pediatric patient. Right? Why claustrophobia? Why is that important? If you've done eyes, you know that the patient is covered from head to toe, right? And the patient may have oxygen on their face, right? But with a drape right there, it can be very uncomfortable for them, and they need an outlet for the carbon dioxide as well. Okay? In these patients that are having a keratoplasty, we must avoid ketamine, and we must avoid succinylcholine. I didn't put that up there because I forgot, but we must avoid ketamine and succinylcholine. And either an LMA or an intratracheal tube is fine. I don't ever remember personally doing a keratoplasty, doing anesthesia for one. I might have and I've forgotten, but have any of you guys done one? Yeah? So did you put your patient to sleep for it? Yeah, typically? Okay. So the answer is yes. Typically everybody's put their patient to sleep for this. So I don't recall, again, having to do one, but maybe I have. I haven't done a ton of eyes in my career because I typically avoid that room like the plague. All right? The advantages of doing regional anesthesia for these patients, obviously it's going to benefit for intraoperative and postoperative analgesia. It too will offer the akinesia of the eyeball that the surgeon needs. I put there no ocular cardiac reflex, but it should be, the risk should be minimized, all right? Less risk of post-op nausea vomiting, so decreasing the incidence of vomiting, which vomiting, remember, increases intraocular pressure by 30 to 40 millimeters of mercury. And of course, the patients hopefully going to have a quicker recovery and discharge. If you've done a keratoplasty, how long was the procedure? You remember? Henry? Suzanne? Anybody of distance land? I have varying notes here, meaning that typically if it is going to last more than 2 hours, it'd be a good idea to do a general anesthetic because your baby's going to get tired of laying still. All right, but I don't know what the average time for it is because I did not look that up. All right, just be aware that if you're going to do a retrobulbar block on this patient, it's going to increase intraocular pressure, but if negligible, by 4 to 6 millimeters of mercury. If you're going to do a peribulbar block on this patient, which we'll talk in a little while, it has a much wider range. It's going to increase intraocular pressure from anywhere from 5 to 22 millimeters of mercury. So I think it would be better to do a retrobulbar block on this patient if you're going to do one. Topical anesthesia for this patient is really not an option at all because they need much deeper anesthesia than topical will allow. And if for whatever reason they do choose to do a topical anesthetic, one of the common issues with it is that the patient has pain toward the end of the procedure. So if your patient has open-angle glaucoma and medications have failed, I told you that they may need a trabeculoplasty or a trabeculectomy. Well, this is what it is. All right? It's a surgical incision of the trabecula. And the ophthalmologist is creating a filtration web that increases drainage of aqueous humor and decreases intraocular pressure. They may want or they may choose to have antimetabolites like mitomycin C and 5-FU administered to prevent flap closure. So mitomycin C and 5-FU may be administered to prevent flap closure. One of the techs that I work with in San Antonio has a tergium, and I've tried to get it taken care of, and she won't. It bugs me to death every time I see her. So a tergium is a triangular wedge of fibrovascular conjunctival tissue. This is also known as surfer's eye because it is caused by exposure to the sun. It typically starts in the medial aspect of the eye and extends laterally onto the cornea. There's about a 30 to 80% recurrence rate, so mitomycin C is often used to prevent recurrence. The mitomycin C is an alkylated agent that inhibits DNA synthesis. Topical anesthesia for this should be fine. There shouldn't be any issues with providing topical anesthesia for this. I've had patients for ectropions and intropions before. They're almost always older, but I've had a couple of younger folks for it. And ectropion is when the lower eyelid is turned outward. And typically it's from effects of aging on the eyelid, or it could be from mechanical or congenital lid pathology. Anesthesia for this can be local anesthesia by the ophthalmologist with sedation by you. An entropion is when the lower eyelid turns inward. That's typically, again, from effects on aging, And again, you're going to provide sedation, and the ophthalmologist will do local anesthesia for it. The next eyelid surgery is the blepharoplasty. I've done plenty of these, for sure, and I actually need one myself. So if you want to do my anesthesia, all right. The blepharoplasty is just excess skin above the eye. This lady, to me, on the left picture, the beforehand picture, looks like she's as mean as a snake and she'll bite your head off. On the right-hand side, on the other hand, she looks much better. This is not immediately post-operatively, obviously, because her eyes would look like raccoon eyes, because these patients bruise incredibly. All right. So a blepharoplasty can be performed to correct a defect, a deformity, or a disfiguration of the eyelids. It is considered plastic surgery unless the skin is affecting the patient's vision. Okay? It's considered plastic surgery unless it's affecting the patient's vision. There's a couple of approaches that they may take, the transconjunctival approach versus the skin approach, and I'm not even going to ask you that. Typically, these are done under local anesthesia by the ophthalmologist and sedation by you. Ptosis is, again, it can be a plastic surgery, but oftentimes is required because of vision impact on the vision. It is drooping of the upper eyelid that impacts the visual field. It can happen from aging, from trauma, or it can be a congenital thing. And once again, so you provide sedation while they do local anesthesia. I've done a lot of strabismus repair. We had a young doc years ago when I did my pediatric rotation. I did 2 of them at Children's Hospital, and he and his brother both did eyes. And man, they bring in 20 kids a day, and we'd rock them out quickly, boom, boom, boom. And half of them were strabismus repair. And what it is this is malalignment of the visual axis, and the patient has double vision. These kids commonly are trisomy 21 kids. They may have cerebral palsy. They may have hydrocephalus as well. Then again, they may not have any of that. I've seen plenty of kids that didn't have any of that that had strabismus repair. All right. Be aware though that these kids are prone to have malignant hyperthermia and myotonic dystrophy. All right. They're prone to have malignant hyperthermia and myotonic dystrophy. This is absolutely the most common eye surgery in children. Typically, the kids don't have a lot of post-op pain, but because of manipulation of the extraocular muscles, they have post-op nausea vomiting is significant with them. So we use combined therapy for antiemetics, and we try to avoid opioids if we can, and give medications like Toradol. Because these are typically children, I think I've done 1 on an adult, maybe 2. Because they're typically children, they're not going to lay still for regional anesthesia. So they're oftentimes do general anesthesia with regional anesthesia as well. Eye trauma. One of the first things we have to realize is that if there's an eye trauma to the eye, we also have to be aware, is there head or neck trauma present as well? Okay, so hopefully the C-spine has been cleared by the time that patient gets to you if he or she has had eye trauma, right? If your patient has the need for general anesthesia, then are we going to give them succinylcholine? Well, that's a mixed bag also. I told you that succinylcholine is one that clearly increases intraocular pressure. We're going to say for purposes in here, you're going to avoid succinylcholine, right? In a patient with eye trauma, you're going to avoid succinylcholine because that's the traditional, most conventional, cautious approach, all right? Because more recent references say, you know what, succinylcholine is okay because we haven't really seen any patients where succinylcholine was given and aqueous humor leaked out. Well, do you want to be the N of 1 that hasn't happened? I don't think so. So we're going to say avoid succinylcholine and do a rapid sequence induction with rocuronium for this patient, okay? We need to make certain that we decrease this patient's gastric volume and gastric acidity, so give them sodium bicitrate. Consider because that patient's had trauma and because they're having their eye worked on, they're at risk for significant post-op nausea vomiting. They may need an oral ray tube, which you guys know what that is already. to keep out of the surgeon's way. And obviously, we want to make certain that we avoid hypercapnia. So we have this dilemma. We have to put this patient to sleep, right? We don't want any aqueous humor or yuck gel, vitreous gel coming out of the eye when we put that patient to sleep. But yet we also have to make certain that we don't cause pulmonary aspiration. So we have to consider what drug are we going to use, what drugs are we going to use, and what, including in those drugs, what neuromuscular blocker are we going to use? Preferably a non-depolarizing muscle relaxant. Okay. All right. Tell you what. Let's take a quick break for 10 minutes. We'll come back and finish up eyes, and then move right into ENT. Okay. Come back at 3 o'clock Central Time. All right, you guys ready to get started? It's now 3 o'clock. Hey, 2 things before I forget. Mobile ladies, I don't know if you know already, but I'm coming to see you. I'm going to email you soon to tell you my dates that I'm coming to see you in Mobile. And somebody reminded me that you do not have class next week. We have priority interviews for applicants next Monday, Tuesday, Wednesday. So you do not have class. The expectation is that you will be in the operating room instead of being in class. Okay, you cannot use this time to study. You should be in the operating room because all your clinical coordinators know that you're not in class. So don't try to fib to them. I had somebody at JPS, not the recent class, not this class. Somebody sorry graduated, try to tell me, oh, we don't have class today, but I'm just going to go ahead and leave anyway. Is that okay with you? Listen, that ain't up to me, but I bet you're going to be told no. Guess what? That was not okay. So don't try to weasel out of it. Don't try to fib your way out of it. There is no class next week because we're doing interviews, but you're expected to be in the operating room. All right? Let's talk about the different types of anesthesia for eyes. Okay? This is the part that really grosses me out because I don't want any needle stuck anywhere near my eyeball. Okay? So, all right? Excuse me. Obviously, eye surgery, typically most eye surgeries require akinesia of the eyeball. And so doing that, obviously, general anesthetic, a retrobulbar block, and a peribulbar block are going to provide akinesia of the eyeball. A topical anesthetic is obviously not going to. Regional anesthesia obviously has its advantages over general anesthesia. I already told you, there's less risk of post-op nausea vomiting. There's less, your patient's going to get out of the hospital sooner. Your patient has post-operative analgesia. But one of the drawbacks to doing a regional anesthetic for these patients is that if they're a chatty Cathy or a talkative Ted, that can be a real problem, all right, because it gets really irritating really fast for both us and the surgeon, okay? So be aware that they may get really chatty. Sometimes even with the more drugs you give them, they get even chattier. But it can also be an issue for patients. Again, I told you, claustrophobia can be an issue. And so these folks need some kind of air, typically blowing underneath the drape. So you can put the bear hunter hose underneath there to help them, or put a bear hunter blanket on them with ambient air flowing. That will benefit them. They also need some outlet to get the carbon dioxide out from underneath those drapes, because carbon dioxide can cause problems. Obviously, the accumulation of carbon dioxide underneath there can cause problems. When a retrobulbar block or peribulbar block are done, typically what's used is a 1-to-1 ratio of bupivacaine, 0.75%, and lidocaine 2% without epinephrine. So a 1-to-1 ratio of bupivacaine 0.75% with lidocaine 2% without epinephrine. A drug called hyaluronidase is often added to whatever local anesthetic they're administering to improve the onset of the block and to improve the density of the block as well. All right? So it's added to speed tissue penetration and improve the density of the block. It also has a benefit of preventing anesthetic-related issues, local anesthetic-related issues that could cause injury or damage to the extraocular muscles. So it prevents injury to extraocular muscles from local anesthetic. So let's talk about these two blocks. Again, I'm not going to ask you questions about where the needle goes because more than likely you're not going to be doing these blocks on your own, meaning you're not going to be doing them at all unless you go to an eye center and that's something that you choose to do. Retrobulbar block, but you need to be aware that the retrobulbar block is injected behind the globe of the eye. It's injected behind the globe of the eye and provides akinesis of the extraocular muscles through an effect on cranial nerve 2, 3, and 6. It provides a sensory block of the conjunctiva and the cornea. The most common complication, you must absolutely know this, the most common complication with a retrobulbar block is hemorrhage. So think about it, I'm going to tell you, think about the patients that you're not going to do a retrobulbar block on, all right, who are not candidates for it. All right? How do we know if there's a retrobulbar hemorrhage? So if the surgeon tells you that there's significantly increased intraocular pressure after the block is done, then that is an indication that there is a retrobulbar hemorrhage. Other complications can include local anesthetic toxicity from accidental IV injection, arterial injection, which would cause high brain levels of the local anesthetic. That could cause CNS excitation, including seizures. I told you it could cause the stimulation of the oculocardiac reflex. It can also be a preventative measure, but it can also cause it to happen. And most of you didn't get this question right on the test. It can also cause a high spinal. All right, so a few of you did. So when I talk about the test, I'm talking about your last quiz. When I said your patient has had a brachial plexus block, and your patient becomes apneic and flaccid, what's the problem? That is not a patient that's had an IV injection. That's a patient that's had a high spinal from a interscalene block or a brachial plexus block. Yes, it's possible. I've not seen one. I was working with one of our folks right after the quiz, and he said, "I just don't know how that could happen." I said, "Somebody not doing their job very, very well at all, but it could happen." All right, so there's a known complication with a retrobulbar block now. Typically, this is a patient, this patient has a needle stuck in their eyeball. No, I'm kidding. It's a 23 to 25 gauge needle that is appropriately placed. And there's only about 2 to 3 mLs of local anesthetic injected, right? So only 2 to 3 mLs of local is injected in there. That's all I expect you to know about it. I don't want you to know where the needle goes, that kind of thing. Be aware also, one thing I didn't include in the complications is with this block, there is a risk of globe puncture. There's risk of globe puncture with this one, whereas with the peribulbar block, there is no risk of globe puncture. When your patient, and one more thing I need you to remember, after this is done, your patient is going to have some intorsion on the downward gaze, so their eyes don't look toward their nose when they look down, because the superior oblique muscle is outside the muscle cone and may not be blocked. So how do I know that the block is effective? All right, is that your patient may have a downward gaze that looks inward at their nose, and that's from the superior oblique muscle not being blocked, while all the others are. So remember that as well. The peribulbar block does not have the risk of globe injection or globe puncture. That patient has an injection above and below the globe, and it provides akinesia of cranial nerve 3 and 6. It does not block cranial nerve 2, on the other hand. While it prevents a retrobulbar hemorrhage, it is slower acting than a retrobulbar block. So this block needs to be done at least 20 minutes preoperatively, before incision. This is said to be less painful and easier to perform. The risk associated with it are high spinal and the possibility of intraocular ejection, but unlikely because, again, there's no risk of globe puncture, according to multiple different references. I think I put that intraocular injection on the wrong slide. I apologize. Intraocular injection should be on the retrobulbar slide, not this slide. So this is just how a peribulbar block is done. Please don't ever do this to me with me anywhere near awake, okay? Topical anesthesia is typically done with 0.5% proparacaine. The block is only limited to the conjunctiva, the cornea, and the anterior sclera. It does not block the iris or the ciliary body, so there can still be pupillary constriction and dilation. A couple more slides about eyes and we're done with this part. Ischemic optic neuropathy, there are a couple different kinds, and I'm going to talk about just one of them. All right? The anterior kind is injury of the optic nerve from insufficient blood supply. Typically, it is a sudden onset issue that's painless and only affects one eye, so it's unilateral. These patients have a poor prognosis. Those treated with corticosteroids have a 70% recovery versus those without treatment with corticosteroids is a 41% recovery. So there is benefit. There's said to be some benefit with administration of steroids. But still, the prognosis is still poor, even at 70%. There's the arteritic versus the non-arteritic kind of ION. Obviously, the arteritic kind is caused by temporal arteritis and will respond to steroids, but the non-arteritic kind is more common. It's more likely to be found perioperatively and mostly found after cardiac surgery, instrumented spinal infusions, some kind of head and neck surgery, ortho joint surgery, nose and sinus surgery. Essentially anywhere where they're working around the eye or your patient's going to be prone or there's risk of hypotension. Considerations for this or ways that it can be prevented is to limit surgical time and limit blood loss. Obviously, we don't have the ability to do that. The reason I have is staging up there an option, meaning that if you're heading into a 14-hour procedure, is there a way to do it in 2 7-hour procedures? All right, do it 7 hours today, do it 7 hours tomorrow. That's why I have staging up there. So in other words, if it can be minimized on day 1 and resume on day 2, then do that. All right. In these patients, monitoring the CVP is said to be beneficial as well. We keep their head of the bed equal to or higher than the heart to prevent ION. And this patient should be consented with a risk explanation that ION is a possibility, right? And I think I told you, some of you, about when I was in California, we did some long back surgeries, and the patient was never consented by the neurosurgeon that ION was a possibility, that blindness was a possibility. And so then we went back and forth about who really should be consenting the patient. It's really a surgical problem, not an anesthesia problem. So we put it on them, they tried to put it on us, and went back and forth. So it's one of those things where and now I don't remember who wound up doing it. We probably both did at that point, right? And that looks like just a duplicate slide to me. Any questions about eyes, anesthesia for eyes? Yes, none. Very good. Let's keep moving. For ENT anatomy, I am not going to ask you any questions from this slide. There's not going to be a picture on your test to say, tell me what this is. That's not important right now, all right? What is important is you understand what you're going to be doing and things that to consider when you're doing ENT anesthesia. Again, this is just a look at anatomy of the airway. That's nice to get reacquainted with every now and again, all right? Let's talk about the right and left recurrent laryngeal nerve. We know that those provide motor innervation to the intrinsic muscles of the larynx, except for the cricothyroid and inferior pharyngeal constrictor muscles. And it says right there what controls those: the superior laryngeal nerve. The right and left recurrent laryngeal nerve also provide sensory below the vocal cords and upper trachea. The internal laryngeal nerve, which is a branch of the superior laryngeal nerve, provides sensory innervation to above the cords. So below the cords, it's all about the recurrent laryngeal nerves. What if one of these or both of these is injured? If your patient has an injured unilateral injury of the recurrent laryngeal nerve, he's going to talk like this. He's going to be really hoarse talking, right? Your patient that's a smoker may also sound like that, but your patient is going to be hoarse. What has happened in that case is that there is abduction of the vocal cord in conjunction with an intact cricothyroid-mediated adduction. So there's abduction of the vocal cord and adduction of the cricothyroid muscle. The affected vocal cord assumes a paramedian position. If there is bilateral nerve injury of the recurrent laryngeal nerve, thank God I've never seen it, that I'm aware of, can result in dyspnea, stridor, and full airway obstruction. Because both vocal cords are paramedian, and those patients are going to require a cricothyrotomy or a tracheostomy, one of the two. Okay? That would be very, very bad. So let's talk about ear surgery. You're going to find that children oftentimes have ear surgery for ear tubes, right? So I've done multiple different things. I've done anesthesia for a barrette to come out of the ear or out of the nose. I've taken bugs out of the ear before, or been done anesthesia for a bug to be removed. So foreign body or removal of tumors, cancers out of the ear, you name it. Myringotomy is a very common procedure for kids or ear tube placement. Right? Tympanoplasty is also a possibility, especially in teenagers, it seems. Stapedectomy and mastoidectomy are also possible. These patients may have experienced hearing loss or some kind of infection, recurrent infections, like otitis media. These patients may also need hyperbaric oxygen and having ear tubes placed for that, okay, to make certain that they don't have issues with their eardrums when they have hyperbaric oxygen. Any type of ear surgery, this patient is absolutely prone to post-op nausea vomiting. Any ear surgery, they're prone to post-op nausea vomiting. So external ear surgery, you see there. Middle ear surgery, you see there. And an inner ear surgery is when someone has a cochlear implant done. And my older brother, had a cochlear implant done because I wear hearing aids. My older brother's almost deaf. So just be aware of that it can happen. And so, all right. So ear surgery, I'm going to read this to you just because it's easier than trying to just paraphrase it. Damage to tissues caused by an inability to maintain near equivalence between middle ear and ambient pressures. That's the definition of barotrauma from one reference. The tympanic membrane really does not have much movement at all. All right? It has very limited mobility and can only accommodate very limited volume changes, like 0.2 to 0.3 mLs. In this case, the pressure is directly related to the volume injected, or in the ear at all, behind the ear. Anesthesia for these patients may include general anesthesia or IV sedation, obviously depending on the type of patient you have, the age of the patient. You may need a reinforced or rave tube for this. Back to the nitrous oxide discussion. We didn't talk about it under eyeballs so much, but I didn't have a slide for it for eyeballs. But for ENT surgery, the same thing. Fixed log diffusion applies. And so especially if you're working with doing a tympanoplasty, you're going to avoid the use of nitrous oxide because of the risk of expansion behind the eardrum and causing problems. I told you that myringotomy or ear tubes, that's the BMT, bilateral myringotomy. A stapedectomy is possible. If your patient has it, they may have experienced otosclerosis. These patients oftentimes have laser surgery, so we need to use laser precautions. They may have the need for facial nerve monitoring. And a surgeon very well may request deliberate hypotension to minimize blood in his operative field. These patients are at extreme risk of post-op nausea vomiting because they're having middle ear work done. We try to give everybody a gentle emergence, but these folks really need a gentle emergence without any coughing, bucking, you name it. So oftentimes they're extubated deep. Last time I gave this presentation, I was scheduled at JPS the next day, and I swear, with no lie at all, I walked in and had a panendo to do. So the panendoscopy is a 3-in-1 procedure. The patient has a laryngoscopy, a bronchoscopy, and an esophagoscopy. Typically, the patients are being ruled out, evaluated for some kind of head and neck cancer. These patients may have or may need a micro laser endotracheal tube. So when you see later on MLT on a slide, that's what that is, micro laser endotracheal tube. Right? These patients may require jet ventilation with a rigid laryngoscope. We'll talk about that in a moment. But these patients, if you're doing jet ventilation with a laryngoscope, with a rigid laryngoscope that the ENT doc is using, There's no way to get anesthetic gas in there. They don't have an intratracheal tube. There's no way to have any kind of anesthetic gas given. So what are you going to do? TIVA, okay? These patients may need a tracheostomy ahead of time. And they may do a transtracheal jet ventilation. I've done that once for an elective procedure. It wasn't a pandendo. I can't remember exactly what it was, but I did electively once at Travis Air Force Base in California. Again, these folks typically are being evaluated for head and neck cancer of some sort, and we have to consider what does the surgeon want. So there's a lot of communication that goes back and forth. If you're a Baylor All Saints you work with, can't think of his name, but is it Duchek or Dubicek or something like that? Anyway, he does a lot of head and neck cancer stuff. This is what's called an anterior commissure laryngoscope. And what this is used for is doing a panendoscopy, all right? And you see there on the left-hand side, it's used as a Miller blade, essentially, but you see what's going on is that it's put in place as a Miller blade, and then the head is suspended on it, right? So you have to be cognizant of the extreme stimulation that this patient is going to have, right? Because of the extreme stimulation the patient is going to have, if you're going to give opioids, which opioid might you choose? What's that? How about remifentanil? Absolutely. Because of the extreme stimulation and the need for that drug to go away quickly, consider remifentanil. All right? So essentially, this anterior commissure laryngoscope is a Miller blade, and it's constant laryngoscopy, essentially, all right, for an extended period of time. These patients usually have a throat pack inserted to block the esophagus and blood from getting into the esophagus. You're going to note what time it was put in and when it was removed. You absolutely do not want to extubate that patient with a throat pack still in. The patient's going to have their head extended and their neck flexed. They'll probably have a head or probably a shoulder roll and the head ring underneath their head, like the gel donut, if you have one. They obviously are going to need general anesthesia with very good muscle relaxation. And again, a very potent opioid, if you're using opioids for this case. The type of endotracheal tube, once again, you may need a ray tube. Be aware, though, that with a ray tube, as you're going to need a smaller diameter so that the surgeon can get to where he needs to get. The ENT doc can be where he needs to be. So you need a smaller diameter. Well, as with a ray tube, the length of the tube gets shorter as the diameter decreases as well. So if I've got somebody that's 6 foot tall, then that tube's not going to be long enough if I choose a 6.0 tube, for instance. All right? So that's just an example. So you may also use a laser endotracheal tube, a wire reinforced tube, or what I told you, the microlaryngeal tube. They make microlaryngeal tubes that are smaller in diameter and appropriately and long enough to get to your patient or reach the trachea. All right? So on the left-hand side, you see a nasal ray and oral ray there. On the upper right-hand side, you see the reinforced tube. You see that on the bottom right, you see that even if you kink or tie the reinforced tube in a knot, air will still flow versus the other way around. All right? If you're using an MLT tube or a micro laser tube, that's going to provide airway protection, going to provide ventilation control, and end-tidal CO2 measurement. Okay? Now, if the surgeon sees something, if the ENT doc sees something in there that he needs to laser, right? What's one thing that you're going to do differently if he needs to use a laser? What FiO2 would you use for this patient? Very low. Okay. There was just a news report about a multi-million-dollar settlement for a kiddo that they said there was poor communication between the anesthesiologist and the ENT surgeon, and sure enough, they described this in the media. So they described this kid's face as just basically a ball of fire after the laser was initiated, and it's essentially that the FiO2 was way too high. All right. You should use an FiO2 of 0.2, as close to 0.21 as you can. All right. So close to 21% as you possibly can. Right? Disadvantages of micro laser tube, these are all advantages, but disadvantages include the fact that, well, you may have higher ventilation pressures or higher peak airway pressures because of the smaller diameter. Even though it's a micro tube, it could still make surgical access challenging. And even though it's a micro laser tube, it's supposed to prevent issues, it can still have problems with ignition and cause an airway fire. So things that we're going to potentially do is if you're doing supraglottic jet ventilation. So in other words, there is a jet ventilator hooked up to that anterior laryngeal commissure laryngoscope. Then that's called supraglottic jet ventilation. So it's high pressure oxygen delivered at 20 to 50 psi. Very high pressure. And remember when we talked about in-simulation doing jet ventilation through the cricothyrotomy catheter or needle in the neck? It's 1 second on, 3 seconds off. And there are times that you may have to push on your patient's chest to make that patient actively exhale. All right? Now, the drawback to this is that there's a Venturi effect. It's supraglottic, so you don't have an endotracheal tube through the patient's airway. As the chest rises, it's going to draw in air, room air, as well as the oxygen from the jet ventilation. All right? So there's this Venturi effect. So the FiO2 that you're delivering is not really 100%, or pardon me, the percentage of oxygen is not really 100%. It's mixed with room air. All right? So there's a Venturi effect with this. The other thing is that you cannot monitor end-tidal CO2 with this as well. All right? So that's a drawback. The fact that you have to use TIVA, well, that may be a benefit, but you're going to have to use TIVA for this as well because, again, you have no endotracheal tube in there. You try to turn on gas, you're going to fumigate the entire room, and everybody's going to be asleep. There's a drawback or risk of barrel trauma in this case. While there's no measurement of end-tidal CO2, there's no measurement of the tidal volume as well. Clearly, this is going to be suboptimal in patients that are obese. And I wrote myself a note on here that I told you it's at 20 to 50 psi. You know, the anesthesia machine goes from 0 to 70 centimeters of water pressure. Just so you know, 50 psi, this is your trivia, is equivalent to 3,515 centimeters of water pressure. That's a lot of pressure. Holy smokes. All right, we're almost done. So let's talk about Lafort fractures here for a moment. If you have a patient that comes to you as a trauma from some kind of motor vehicle accident or what have you, right, they may have some kind of facial fracture. So a Lafort 1 fracture is a horizontal fracture. So it goes straight across, and it involves the inferior nasal aperture. Essentially, it separates the teeth and the lower maxillary components from facial structure. This is associated with significant blood loss. The Lafort 2 fracture, on the other hand, is this. You see that triangular fracture? It involves the orbits, the entire maxilla. So there's this fracture line across the nose, along that infraorbital rim, and the entire lower maxilla. Bad news. And this one's really bad. Lafort 3 fracture, so it parallels the base of the skull. It's a fracture of the nasal bones, orbital bones, and the zygoma. In this case, the maxilla is fully free and mobile and could cause airway obstruction. This isn't common at all, and I don't know that I have seen it even being deployed. I'm not sure that I've seen this. I have seen Lafort 1 and 2 fractures deployed before. Now, you're going to get patients that have Lafort procedures done. You've worked with me at JPS or anywhere else, you may have done some. But back to Lafort fractures, the patient is going to, we have to rule out head and neck injury as well, just like with open globe procedures. There could be chest trauma from this. So if the patient had an MVC, they may have been hit with an airbag in their chest. These patients, of course, are considered a full stomach. They very well may have a bloody airway, obstructing view of the vocal cords. And obviously, they should have limited range of motion. And when I teach you to intubate, I typically tell you to put your hand on the top of the head and extend their head. Yeah, you don't want to do that with these folks. So there are folks that look like this that can have a Lafort osteotomy done. Does this kid look familiar at all? This is my oldest son. So he had a Lafort osteotomy done about 5-6 years ago. And it's used to correct maxillary deformities. This is Noah. He had a terrible, terrible underbite. And so he had his maxilla advanced and his mandible receded. So it corrects malocclusion of the teeth by movement of the maxilla and or mandible. And so he had what's called a Lafort 1 procedure done and a BSSO. And so I just finished teaching, or just about finished teaching, the folks in simulation about nasal intubations, that kind of thing, and talking about afferent spray and this kind of nasal tubes and so on. And now I have to ask you guys, now you're in clinical practice. I told you when you were in there, I don't believe in dilating the air with the rubber hoses up the nose. Have you worked? Does everybody do that pretty much? Have you done nasal? Yeah. Why do they do that? I don't understand. So do you really think it dilates the air? I don't. But anyway, moving on. All right, so this is what he looked like afterwards. I made a mistake of sending this picture on the left to everybody just to say that he was done. Little did I think about the fact that, well, I'm the medical person, I could tolerate this. It was my own child. All my family did not appreciate that picture at all. So later on, I was in San Antonio, and we were FaceTiming. I put this here just so that you see the extent of the swelling post-operatively, all right, and bruising, and the bruising can extend into their upper sternum area. So just be aware of that. And then this is a difference on the very right-hand side. You see what he looked like with the underbite, and then just next to it, this picture is what he looked like not long after his surgery. All right? So they're very effective, but they can be painful because patients can be wired shut for these procedures. They can have a significant amount of pain and a significant amount of post-op nausea vomiting. All right. So let's talk about what we do for it. Typically, these patients are younger than 30 years old. All right. But I'll tell you, just not long ago, somebody was doing anesthesia and had a patient that was actually an oral maxillofacial surgeon himself, and he was in his 40s. So everybody, he was having a Lafort 1 done and so on. All right. These patients typically need a nasal ray tube placed, but there's one particular OMF here in town that doesn't like a nasal ray placed. He wants a straight tube in there. So it just varies depending on who you're working with. They absolutely require deliberate hypotension because they want to minimize the blood loss. When they're drilling, when they're grabbing this, grabbing that, they don't want a lot of blood loss. So you're going to communicate with the oral maxillofacial surgeon what is an appropriate MAP for you. Typically, it's about 55 millimeters of mercury. And I usually document that Dr. Stella, Dr. Warner, Dr. whoever requests a MAP of 55 millimeters of mercury. Okay? And so you may have to put them on run your gas high, and run your opioid infusion high if that's what you're doing, and put them on a phenylephrine infusion. It varies quite a bit. Okay, we try not to give them a lot of extra IV fluids because of the swelling that's going to occur intraoperatively and postoperatively. These folks typically get 10 to 12 milligrams of Decadron or dexamethasone IV before the surgery begins. It's always a good idea to do multimodal post-op nausea vomiting prophylaxis and now multimodal pain management as well. And these folks absolutely must be awake. Absolutely must be awake before you extubate them. They absolutely have to maintain their own airway before you extubate them, all right? Because they are at risk for a cricothyrotomy afterwards, significant risk. Every OMF patient that we go to the PACU with at JPS, if they're wired shut, they go with a cric kit to the PACU and it follows them until discharge because of the risk. Because they would rather the patient get criced than to cut the wires, all right? Because they've done all this work, they don't want you cutting the wires, they want the patient criced instead. Okay? I've never had to do that for this procedure, for an oral maxillofacial surgery, not an elective procedure like this anyway, all right? So I gave you the general gist of this. Once again, post-op nausea vomiting can be significant. The swelling is typically what causes the discomfort. Interruption of nerve integrity, stretching of nerves in these patients oftentimes decreases their pain afterwards. It's the swelling that causes the pain. Be aware, just so you know, for your practice, not on the test. Okay, let's talk about nasal surgery. Nasal surgery can include any of these that I put up there, turbinectomy, septoplasty, so on and so forth. And so you have to be aware of these patients, and obviously all patients, we need to know whether they have sleep apnea or not. Maybe they have hypertension. They might even have Samter triad. You guys remember what that is from class? So good. Asthma, nasal polyps. So the sensitivity to aspirin or NSAIDs can cause bronchospasm. That's Samter triad. Right? These patients may have their procedure done under local anesthesia. They may need general anesthesia with a ray tube. Nasal surgery can be really fraught with intraoperative and post-op bleeding. So we hold their nonsteroidal medications or aspirin for 1 to 2 weeks preoperatively. Now, if your patient's taking 81 milligrams of aspirin preoperatively for cardiac issues, that may not necessarily need to be held. Okay, so that's communication with the ENT surgeon and pre-op. All right, these folks oftentimes have a vasoconstrictor used in their nose. Some ENT guys, gals, still use cocaine for vasoconstriction. It's 4% cocaine, and we don't want them to exceed 1.5 milligrams per kilo. They may use phenylephrine pledgets or phenylephrine spray. It may be used by itself or with lidocaine. The initial dose is typically under 500 micrograms, but we also have to be aware that severe hypertension is possible with these patients. And the last one is Afrin. All right, it has a much better safety profile than the other two, and can be used preoperatively. And that's a concentration of 0.05%, and we just do 3 sprays in each nostril. Afrin, just so you're aware, is a selective alpha-1 agonist and partial alpha-2 agonist. We don't use Afrin in patients that are taking MAO inhibitors. Endoscopic sinus surgery has come a really long way. I had endoscopic sinus surgery in 1994. It was under direct vision. Now, holy cow, there's all kinds of mapping done for this procedure and everything. And I think I have a picture of it later on. But it's done for nasal polyposis, sinusitis, chronic nosebleeds or epistaxis control, tumor excision, foreign body removal, septum issues, you name it. All right? These folks also need, as best possible, controlled hypotension to prevent blood being in the field. Remifentanil is yet again another great opioid for this, an opioid infusion for this. And it provides for a very smooth wake up for the most part. I have supraglottic airway there versus an entracheal tube. Only because it's in the literature that someone may need a supraglottic airway. But I've not seen it, not heard of it before preparing for this. Typically, everybody gets an entracheal tube and an oral ray entracheal tube. When somebody's having endoscopic sinus surgery, once again, they may have pledgets placed in their nose, pledgets being a long white epi or phenylephrine or cocaine soaked thin piece of cloth on a green string, and they put that in there after the patient is asleep, and then take it out after a minute or two, and they may replace it, they may not. So you just have to be aware that it's being put in there because of absorption through the nasal mucosa. If it's an epi-soaked pledget, then you're going to see potentially hypertension and increased heart rate. Okay, what's common is lidocaine, 1% with epi, 1 to 1,000. There may be cocaine, some pledgets. I thought I fixed that on there, but I didn't. It's cocaine or epi is what it should be. And that patient's most likely asleep and has not been intubated yet. That's why the mouth looks like that. It's just not that the patient's probably not awake and having these shoved in their nose. Right? This is the picture that I was going to tell you, is that there's all kinds of mapping done to avoid the orbits when doing endoscopic surgery. And so they do image-guided, they have an image-guided surgical system for this. And it requires that the patient wear this special headset that can be put on after induction. This is a procedure that's likely, you're doing the anesthesia, the head's going to be turned either 90 degrees or 180 degrees, so there's field avoidance, and you have to make certain, of course, that your patient doesn't get extubated unintentionally. Potential complications with endoscopic sinus surgery include orbital hematoma, if they enter the orbit, which I've not seen, thankfully, or blindness from orbital injury, optic nerve injury, There's a possibility of CSF leak, which I have seen before in the operating room. Typically, those are often seen post-operatively, not in the operating room, but our ENT did a litmus test for it because he was concerned about it, and sure enough. Those patients oftentimes come back 2 to 3 weeks later with this constant drip out of their nose, and that's how they know that they have a CSF leak. There's always a possibility of carotid or ethmoid artery invasion, cranial cavity entry, and of course the risk of hemorrhage as well. We're almost to the end. You guys are doing awesome. We're doing a lot of pediatric anesthesia, comes lots of TNAs, tonsils and adenoids, all right? And you'll do plenty of these as well, I'm sure. The adenoids are the lymphoid tissue that's posterior to the nasal cavity, and when you intubate your kiddo nasally for, say, dental rehab, and they haven't had their tonsils and adenoids removed, you're going to remove their adenoids, or you're going to poke right through them, okay, and cause a lot of bleeding. The tonsils are removed oftentimes for tonsillar hyperplasia, recurrent tonsillitis, and potentially for malignancy. Very important, even in children, that these folks are screened for sleep apnea. They oftentimes have had recurrent upper respiratory infections, and they may even have cardiac issues as well, because they have long-standing sleep apnea and finally get something done about it. All right? Typically, they need an oral ray tube, but there's some literature out there and some folks that say they need to put LMAs in for this. And I'm like, nope, not me, not about to. But no, of course, this is a stimulating procedure. I had one ENT that wanted to start doing these awake, and I said, in no way, shape, or form am I going to do anything with you with a patient being awake. And we did one, and I said, never again. And we never did one again. And I did most of this was in Dayton, Ohio, and I did most of the ENT surgery there for a long time, most of the ENT anesthesia. These folks, again, really benefit from a remifentanil infusion because of the smooth wake up. You can keep them on a low dose as you emerge them. Used to, it was a turn it off at the end of the procedure, and the patient will be awake in 8 minutes. They won't buck. They open their eyes. They're ready to extubate. These folks have severe post-op pain. The pain is worse when the older they get. And that's not a lie, that's not exaggeration. If you've ever known anybody or had your tonsils out yourself as a teenager or adult, it's significantly worse than children. So they have significant pain. People or ENT docs try to prevent or minimize the risk of pain by injecting the tonsillar pillars with local anesthetic. I'm going to tell you from clinical practice, it doesn't do jack. Okay, injecting in there doesn't do anything. They typically need morphine or hydromorphone. We obviously want to avoid NSAIDs because if that patient comes back bleeding and you gave that patient Toradol, then guess what's going to happen? The finger's going to be pointed right at you for causing that post-op bleed. All right? Speaking of post-op hemorrhage, this is an absolute scary haul your butt to the operating room emergency. Okay, this patient can lose a lot of blood very, very fast. All right, typically it's going to happen within about 6 hours post-operatively, but it can happen after the patient's gone home, even the next day. All right, if they're not staying hydrated enough, or they start eating potato chips and so on, which I've seen happen before, they can come back with a post-op hemorrhage. These folks come into the emergency department, and the family typically says, "Oh, they have their tonsils out," and you're the second phone call that's made. The first is to the ENT doctor, get their butt to the hospital right now. These folks need to have IV fluid resuscitation, and they are absolutely 100% considered a full stomach, meaning it could be blood in there, it could be anything. And so we consider them as they have to be induced with rapid sequence induction and intubation. And you absolutely remember, we teach you, have your suction up and on. So when you find what you're looking for, all you gotta do is reach down, grab it, put it in. This is why, okay? Because there's gonna be a ton of blood in the airway, be extremely difficult to see. Doesn't matter whether you're using direct laryngoscopy or video laryngoscopy, it can be very difficult to see. And one of the benefits, just for your information, the kid or adult is obviously asleep and quote unquote paralyzed. What somebody can do is, if you can't see well or you're not sure which hole is which, have somebody push on the patient's chest to generate back pressure of air. You see a bubble, and then point your tube in the direction of the bubble, okay? That will give you an idea of
We can't hear you.
here. I think I'm muted. Can you hear me now? Okay, good. Sorry about that, guys. So what I'm saying is, this usually, I don't know what you last heard, this usually happens within 6 hours, but can happen after the patient's gotten home and can come back the next day. These folks obviously need aggressive IV fluid resuscitation.
You are in the Zoom meeting now. This meeting is being recorded.
Wow, I wonder what that was. Hey, Ken, what's going on? We treat these folks as a full stomach because their guts can be full of blood potentially. All right? When you see them, they're probably going to be leaning forward with blood just drooling out of their mouth because they can't swallow very well. This is why, again, we teach you to have your suction up and on, readily available. So once you see the vocal cords or what you think of the vocal cords, so you can just grab your suction, put it in there without losing your view. All right? One of the things I was saying, just from a clinical practice standpoint, if all you see when you do your laryngoscopy is a hole and you can't tell which hole it is, one of the things that you can do is have the provider or somebody else push on the chest for you, generating air coming back toward the back toward you out of the trachea, and that will hopefully you'll see a bubble come back, and then you can intubate the trachea, hopefully, right? These folks absolutely must be awake when they're extubated. There is no deep extubation for these folks. They have to be wide awake, right? Other surgery that you may experience is what's called a UP3 or a uvulopalatal pharyngoplasty. That's a UP3, typically done for sleep apnea. Not very effective, but sold like it is. But typically it's something. So what's being done is a patient's uvula is resected and part of their soft palate. But once and it's extremely painful as well. You may do anesthesia for a uvulopalatal flap, venoglossus advancement, and you can read the rest. All right. Patients that have are having sleep apnea surgery of some sort, say uvulopalatal pharyngoplasty or UP3, these are the things that they may present with, which you already know because you know the dynamics of sleep apnea. They may have a metabolic syndrome. They may have type 2 diabetes. They may have coronary artery disease. Core pulmonale if it's bad enough. They may have a difficult ventilation and intubation. They may be a cannot ventilate, cannot intubate situation because of their sleep apnea. They typically require an oral ray tube that's taped in the midline. And they oftentimes have significant amount of redundant tissue around their vocal cords and a large tongue. We have to be careful that this is oftentimes, any of these surgeries for sleep apnea are typically painful, extremely painful. We don't want to give them opioids, we don't want to give them NSAIDs, but we also have to be very, very careful with opioids because this is not an immediate fix for their sleep apnea. All right, they still have risk of apnea postoperatively, so we have to minimize their opioids and minimize. Hopefully, the ENT doc had minimized their opioids at home. So this is great for multimodal pain management. All right, but we just make certain that we don't give them any NSAIDs at all, just like the patient for tonsillectomy, because these folks are at significant risk of post-op hypoxia because of their history of sleep apnea. These folks tend to have an increase first. They have an increase in their hypopneic episodes postoperatively for about the first 3 days postoperatively, and then returns to preoperative levels after that, after about the initial 3 days, and hopefully get better. These folks typically are given large amount, 10 to 12 milligrams of Decadron as well. Finally, you may get patients that come to you for a trach. I don't know if you remember from last year, if you ever had to do a crike on someone, or a crike had been done on someone that's only good for 72 hours, the patient has to have a surgical trach after that. Your patient's been intubated, or an ICU patient's been intubated for 7 days, so they need a trach done, that kind of thing. I told you about my aunt who I think had fat embolization syndrome. She had wound up having to go back for a trach as well after being intubated for a week. A trach is really not the best option for an emergency. The malpractice case I reviewed a couple years ago was against a CRNA for he lost the airway, and the surgeon on a guy who had ACE inhibitor-induced angioedema. For whatever reason, they didn't choose to do a crike on the guy. They choose to try to do a trach, according to some of the documentation. The documentation was really conflicting, and so it's not really the best for an emergency because it can be harder to find the trachea and harder to enter the trachea. Typically, a trach is done between the second and third tracheal ring. Remember that we don't go between the cricothyroid, cricoid cartilage and the first tracheal ring because of the risk of fracture in the cricoid cartilage. Typically, these patients are intubated already. If they've been in the ICU, obviously, they're coming to you intubated. Has anybody ever have you done a trach before on an ICU patient? And what you know, just hook up the circuit, turn the gas on. You can give them IV medication if you need to, but typically not. They just drift off to sleep with the gas. When they're doing the surgical procedure, you're going to withdraw the endotracheal tube slowly and slightly as they enter into the trachea. And you absolutely must make certain that they have entered the trachea, truly the trachea and not soft tissue, before you extubate your patient fully. I think it's Dr. King. Somebody has an absolute horror story about the fact that the patient was not, they had not entered the trachea like they thought they had, and the trach was sitting in subacute tissue, and it just got worse from there. So you absolutely have to make certain that you withdraw the endotracheal tube ever so slightly. They enter into the trachea, and then extubate the patient fully once they say so. All right. You may have a patient that comes for an awake trach. I've done that plenty of times for patients that had laryngeal tumors or what have you that need to be excised, and so the patient has an awake trach done. So if anything, you sedate them slightly, and that's really it. It's usually with doing an awake trach, what we do is it's okay anesthesia. You know what that means? You pat the patient on the shoulder and say, it's okay, it's okay, it's okay. It'll get better, it's okay, it's okay, it'll get better. I'm sorry you're having to go through this, and so on. That's a patient that is not intubated, right? That's a patient that is going to have a procedure done. They know that the airway is grossly abnormal, or there's some obstruction to the bladder opening. You're not going to be able to get around it, so there's a way to. So they just do an awake trach on that patient and then you put them to sleep after the trach is completed. Okay. All right, that does it. Any questions about anything? It's 3:58 now. I know I went through some of that really fast.